We are on to chapter 8, which is dealing with crisis, disaster, suicide, and while managing stress and avoiding burnout. We've covered that and we've already been talking about it. I'll hit on it just again, just to continue to talk about the importance of it. As always, I like these learning objectives for the new text, which I'm enjoying very much. You're going to need to be able to discuss the different type of crises and ways to provide crisis assessment and intervention, as well as training models for disaster intervention. You need to understand the ways to assess suicide risk factors, and warning signs associated with suicide, and interventions with clients who may be suicidal, including how to talk with them. When we meet in class, I will do a PowerPoint, the suicide risk assessment one, just to continue to give you more information, and we'll practice suicide risk assessments. You'll need to define compassion fatigue, secondary PTSD, and vicarious traumatization, and understand ways to manage stress and avoid burnout, which you've already done a reflection on and we've already talked about. Hopefully you've already read that part of this chapter, which will really shorten your experience. So crisis and disaster response. In your book and in another PowerPoint that I use, I do have the Chinese character up that represents the words crisis. It has two definitions. It actually means both danger and opportunity. And I really like that because while crisis can be very dangerous, also beautiful things can happen out of a crisis. And there can be a lot of growth and opportunity for people. The perception or experiencing of an event or situation as an intolerable difficulty that exceeds a person's current resources and coping mechanisms. It refers to a person's feelings of fear and shock and distress about the disruption, not the disruption itself. I use that a lot when I do presentations. It's not the event itself, it's what happens to you after. the distress about it, the fear and the shock. It's the critical phase in a person's life when his or her normal ways of dealing with the world are suddenly interrupted. Those are the definitions of crisis, disaster, right? There are three essential elements of a crisis. Three essential elements: the precipitating event, a perception of the event that leads to distress, and a diminished functioning when the distress is not alleviated by customary coping mechanisms. A single event may be a crisis. It may cause a person to have adverse effects or not. It depends on the person. It's a combination of the person and the environment and all the other things and systems involved if the person will be okay after the crisis or disaster. There are models of crisis. You need to know these. Memorize the ABCX and double ABCX. So you need to know both of these in the types of crises. So you definitely have to know that from here on out. So it'll be really important that you memorize it. An ABCX model of crisis is an event or situation that becomes a crisis depending on the resources and perception of an individual or family and the degree of stress from low to high generated by the event or situation. Sometimes an event can be perceived as minor by one individual, such as a more wealthy person losing their job may be perceived as a crisis by someone else without any financial resources. The dynamics of such a situation can be seen in the diagram on 8.181 figure on page 195. And that is where the diagram shows how that works. So when you go back and you read through the definition, A is the event or situation. B is the resources that the person has. C is the perception of the individual, family, or situation, school. And X is the stress, the degree of stress for the individual. So when one thing happens with one person, it can be totally different than with another person. So we see that a lot, right? With big natural disasters and things like that, people bounce back more quickly who have resources than who don't. Their stress and their trauma level is higher. And then we have the double ABCX, double A, double B, double C. Sound like I'm on Alice in Wonderland when I say that. Double A, double B, double. Is that the movie? Heaven help y'all for having to listen to these. I do try to make them entertaining so you don't go to sleep. Realize you're just listening to my voice. So let's talk about the double ABCX model of crisis. You have a nice diagram here that makes a little more sense for you. I don't think your text does a fantastic job of helping you with this right off the bat. So let's kind of look at this one instead. You see the stressor, the resources, and the perception and the crisis, which is A, B, C, X. And then you move over into AA, BB, CC, X outcome. So you first assess with ABCX and then you come back and you reassess and compare. So it's double A, double B, double C. So this is with family crisis, but there are other diagrams as well that can help you to understand this a little bit better, and hopefully that worked for you. Okay. The accumulated or multiple aspects of elements, very much more complex, they're saying, than ABCX. Types of crises, developmental, situational, existential, and ecosystemic, and you need to know the definition of all of those. So developmental crises. You take a class in the summer that I teach like this. It's fully online, which is nice. I think for you in the summer to have that, and you kind of go at your own pace. You have something you have to do every week, kind of like this, but the whole thing is online. And all my little lectures are already recorded. And so a developmental crisis is something that happens in our lifespan development, some kind of crisis that occurs. The death of a family member, a parent, having empty nest, going through retirement. They are things that are situational, that can be really normal or really awful depending on the situation. When it's not timely or handled in the way that I'm trying to think. This one in the book's a good one. So, teenage pregnancy. Okay, like it. Wrong place in the timeline. Your mom dies when you're 25. You have you lose your job, and before you thought you would, you're faced with early retirement, and your whole life has changed because of it, and you have to find a new career or something like that. So those are developmental crises. You will learn all about lifespan development. It's a really fun class. And then situational crises. This is you had no way of knowing or controlling the situation. It happened. It was random, shocking, and intense, catastrophic, an accident, a robbery, something like that, a, a hurricane, fire, something like that. And then we have existential crises, which you hear that a lot. They are intense, pervasive inner conflict and anxiety with your purpose, meaning, responsibility, freedom, and commitment. Remember, we just had our great group presentation from Joseph and Stephen reminding us about all those concepts in existentialism. And you hear the term existential crisis a lot, and it's a real thing that happens to people, especially right now when we're faced with mortality, perhaps from COVID-19. So I think it's people are really evaluating their life more right now than they were before. Existential crises are precipitated by non-events, events that do not happen, such as realizing that one is never going to have children or make a difference in their field of work. Maybe they have a job and they've been doing that for a long time and they're good at it, but they are not finding meaning in that, and they want to find meaning in life. So I will tell you, you will find meaning in your career with this. So much meaning and purpose. That's one really positive thing about being a counselor. It's a really beautiful job. So let's see. Also can occur when spouse or partners question the value of the relationship. Also happening a lot right now. Very interestingly, I think people were, evaluating where they are in life and who they're with and not happy whatever. And so lots of interesting things going on right now. This is, I would say, seeing all of these things and so interesting to be able to teach right now in a pandemic and be able to actually use examples that are actually really occurring for all of us in some way, shape, or form. And then we have ecosystemic crises. There are natural or human-caused disasters that overtake a person or group of people who find themselves through no fault or action inundated after the aftermath of an event. These are big events. Um, so I guess that would be more like the hurricane would be here. Take that out of situational. I was a bad example. Situational was more personal, like just you, one person. These are a group of people. So my fault there. A terrorist attack, 9/11, right? The Orlando fire um, shooting. Gosh, that was a shooting. There were all those people that were killed. So also, this includes, like I said, natural phenomena as well. Um, Although crises do represent highly stressful and disruptive situations, they don't always lead to mental disorders, but they can. You can have short-term acute stress disorder or post-traumatic stress disorder um, with these. Oh, and they did this for you, and I just went ahead and did it. But you have nice examples for developmental, situational, existential, and ecosystemic. I probably should have been scrolling while I was talking. But if you go through one of those crises or anything happens and you don't, or you're a victim of trauma in your childhood and things like that, you can develop PTSD. Um, and we know now that PTSD is far more prevalent than we thought it was. In fact, most of my clients who come into the practice get a high score on PCL-5, even if they haven't had what they would deem a big crisis or trauma in their life. The accumulation of small, stressful life events can often cause the same symptoms. It's very interesting for me to see how many people have those experiences. People with PTSD, though, they exhibit a number of symptoms, including the following. You'll have a diagnosis class with Dr. Powers in spring, and that will be very helpful to know exactly how to diagnose somebody. But you re-experience the trauma through flashbacks, and I want to say that's not as like severe as you see in the movies. That can just be like zoning out and just playing it on a tape. So it keeps coming up in their mind and they keep playing it over like on a reel of a tape, avoiding anything related to the trauma. So people, places, things, times of day, like just um, driving another way, and just anything they can to avoid. Intense fear or helpless feelings, being completely numbed out, no feelings, which is the worst. Range of coexisting disorders that occur PTSD. So the comorbid with it. So that's a word that you need to know, comorbid, because they're together. Substance use, OCD, panic disorder, and there are more, especially also um, substance abuse, big high comorbidity. Ooh. Crisis intervention. We're all called to be crisis interventionists at some times. If something big happened in Atlanta, let's heaven forbid there was a bombing or we became like an epicenter for COVID and um, something anyway, what you can just the sky is the limit. Like um, we might be called upon to volunteer to assist with crisis intervention. The goal of crisis intervention is to diffuse the emotions, rearrange cognitive process thinking, organize and interpret what has happened, integrate the traumatic event into his or her life story, and interpret the traumatic event in a way that is meaningful, and that is UDR. That's what we do in UDR. Actually, I'm trained in this, and you could do the same thing in a different way. You assess, listen, act. There are different models of crisis intervention that you would utilize when you went in to do crisis work. But as a first responder for crisis, I can do this protocol called the recent events protocol, and actually don't even have to speak your language. I can just process the recent event and they can tell me about it or just think about it. And I can just bring them back. I play it like a movie and frame it out, and like we go first part process, second part like movie frames. And what it does is dramatically reduce their risk of getting post-traumatic stress disorder. So we get them within the first 6 months of the trauma, and then we can do just that in 2 sessions or one session for an hour and a half to 2 hours. And I'm not going to take the grief away and the pain away, but that's going to be there. But the long-term effects of the trauma will be mitigated by the EMDR. So it's pretty fascinating stuff. These are your primary goals. Assess for safety and other, oh yeah, making sure, like, so if let's say, for instance, you went to where Hurricane Katrina, you would first assess the situation. Are they safe? Are they breathing? Do they need medical attention? Do they need water? Do they need a blanket? How can I connect them with their family? What can I do to get news for them? How can I advocate for them? What do they need? How do I get them connected with FEMA, Red Cross, that kind of stuff? All right. So then you listen. They're going to want to tell you what happened, and you just listen. And you listen and you support and you help them cope, and then you do coping mechanisms and things to help them stabilize. Okay. So there are different ways to do this. James and Gillian in 2017, they have a model to help people cope with crisis. And so it's a 6-step model of crisis intervention. So we're going to talk about that in a second. In that 6-step model, um, we assess, listen, and act, and then it's going to tell you how to do that. So assessment is the severity of the crisis. This is what I just said. Is the client in danger? Do we need a blanket? Are you bleeding? What do we need to do? Is all that taken care of? And we go right into support, resources, and coping. So you're assessing the situation because clearly you need to know what is happening before you move forward. Crisis intervention terminology that's associated with assessment: equilibrium, disequilibrium, mobility, and immobility. So those are terms that you need to know for the assessment stage of what you're doing. Equilibrium is their state of emotional or mental stability and balance. Disequilibrium, there is not stability or balance. Mobility is a state of being able to autonomously change or cope into different moods, feelings, emotions, influences, being flexible. Immobility is a state of being incapable of changing or coping in response to different moods, feelings, emotions, needs, influence. Being unable to adapt to immediate physical and social world. So those are terms that you may need to know with assessment. I have a really good PowerPoint on this that I think I'm going to show you guys. I think it's in the suicide risk, the one I'm going to do with you when we get back in class. And the triage assessment model on page 199, it gives you different domains to assess the client's reaction to the event. And those 3 domains are affective, which are feelings, behavior, which is behavioral, and cognitive, which are thoughts. So those are the 3 domains that would be assessed. Responses in the feeling or affective domain are anger and hostility, anxiety and fear, and sadness and melancholy. Clients can be assessed to see which of those emotions are being experienced by the client and how intense they are. Are they screaming, sobbing? Are they on the other extreme? Are they completely numb and withdrawn and shut down and not unresponsive? Impaired emotional expression is an example of disequilibrium. So going back to those terms of equilibrium and disequilibrium. So those are an example of disequilibrium. In the cognitive, it's approach versus avoidance, and immobility, which we learned that term in the previous slide. Perceptions or thoughts about, I'm sorry, got off there. I went into cognitive and I really meant to talk about behavioral. Let's move to cognitive, which is the third one. Perception is focused on the present. Are they focused on the present? Are they focused on the future? Are they oriented? Are they focused on the past? So they can occur in many dimensions that their cognitions, which is physical, psychological, social, etc. And the behavioral, which is the second one, are approach, avoidance, and immobility. Your clients usually have one of those three behaviors in response to the crisis. When clients are trying to avoid, they try to ignore, deny, or escape. Approach means they are trying to implement strategies to address it. So more approach would be more stable. And immobility refers to a set of behaviors characterized by non-productive, disorganized, or self-defeating attempts to cope with the crisis. Are they helpful? Are they harmful? Is the behavior moving toward a solution or toward stabilization, toward coping, and that kind of thing? Looking for suicidal ideation, homicidal ideation, and then if they are suicidal, you then do a suicide risk assessment to determine risk and then make a determination on what you would do next. That would help you just make a decision on what you would do next. But you continuously assess throughout crises to see how they're doing. You're listening also, and this is the assessment model. So this assessment phase, which you're also listening and then acting. To explain how these functions can be used together, let's look at the 6-step model of crisis intervention from James and Gillian, 2017. And you need to know those, you need to memorize the steps and understand how they work. And the steps are defining the problem, ensuring client safety, providing support, examining alternatives, making plans, and obtaining commitment. This one I like better than psychological first aid. Psychological first aid is something that people are trained in for crisis response, and it is evidence-based and anyone can be trained in it. That's an actual training, and you can look and see where you can go get trained on that modality. Back to this, let's talk about this. So first, in the 6-step model of crisis intervention, you're going to define the problem. What is the problem from the client's point of view? You use your core counseling skills, which are Rogers core conditions, and help the clients tell their story. Help them to empower them using the steps to empowerment and help them stabilize. Number 2, after you begin assessing and looking at the situation, you're going to ensure client safety, minimize physical and psychological danger to self and others, helping them feel safe for now, a sense of safety, normalcy, and some predictability. Provide support. You support them through your care and support in all the things you're doing to empathically respond in a non-judgmental way. And now you look at alternatives in step 4, helping them to make choices to restore the equilibrium, which is something we talked about, disequilibrium, equilibrium. Helping them to find support systems and coping mechanisms to help them with more constructive thinking and planning. You make plans in 5, encourage to select from the different alternatives that were explored. In step 4, helping them to choose something that will support their empowerment. And then you help them to obtain commitment, getting a commitment that they're going to follow through on what you've discussed. So you've got that commitment to definite positive action and follow-up. Please make sure you read through 8.4 on counseling after 9/11 and make sure that you meet the following things for a counselor here. Are you mentally healthy, etc.? Disaster mental health training. This is something that has been very applicable in recent years, and people are receiving disaster mental health training in order to respond in an emergency crisis situation. One of those is called psychological first aid. There's another one that's crisis incident stress management, CISM. Um, but one of these evidence-based trainings is psychological first aid. Um, is the acute intervention of choice. You can find it on the VA website and online as training is available for PFA. It is to protect, preserve safety, health, and self-esteem, direct people to safe places, connect, detect, select, and validate. So read through all of that. That's the 6-step model of crisis intervention as well. But it's more involved and you can get trained in that. So go check that out on the websites here. So making sure that you are trained and highly supported and that you're healthy mentally is really important if you respond to crises because you risk really becoming fatigued with your compassion. So some different terms to know. One is compassion fatigue. And I've kind of used that synonymously a little bit with burnout. A response to helping or being involved with people who experience trauma or extreme predicaments. Secondary traumatic stress, often used interchangeably with compassion fatigue, may exhibit symptoms that resemble PTSD. People can have symptoms that are similar to PTSD, such as exhaustion, hypervigilance, avoidance, and numbing. Long hours in these environments can result in a lot of issues and can make people more vulnerable to secondary post-traumatic stress. Vicarious traumatization is a related condition that's associated with trauma work. Um, it alters the worldview of the clinician. I think I shared with you guys at one point that my mind was a little off, probably from all the trauma work that I had done. And I really had to reel it in and get myself back on track. Um, Regular exercise, relaxing, the meditation obviously have been huge things that have helped me, and I hope they'll help you too. They really mediate the issue with vicarious traumatization, also being highly trained in something such as EMDR is helpful. We talked about self-care already, but making sure that you are committed to this. There are some things we talked about in the other PowerPoint and in your wellness um, activity. So these are really, really important, and there are many ways that we need to make sure we don't get fatigued and burnt out. So symptoms of stress and burnout affect people's ability to function in a number of ways, cognitively, emotionally, behaviorally, and physically. Just make sure you read this. I'm not going to spend a ton of time talking about this because we've really already done it, and we know how much is important. So make sure you understand these. So let's talk about suicide. We're going to talk about this in class a lot. So this is definitely not the only time you're going to see this. But in 2015, statistics said 41,149 people completed suicide. And that's what we're supposed to say now. And I forget to do it sometimes because I was trained to commit, but it's complete. Try to complete suicide. Because commit feels like you're like it's a crime or something. So you just have to be really mindful of what we're saying. 1 million people attempt suicide in any year. That's a 2016 stat. It is the second highest cause of death for college students and people between the ages of 25 and 34. Why do you need to know that? Because if you have a client coming in and they're in that age range, or they're a college student, you're going to make sure that you know that's high risk. And so you're going to be more concerned about that than perhaps someone who doesn't meet that criteria. In 2013, the rate of suicide for adults 65 and older was 16 per 100,000. So that's another high risk group that you often don't think about. And men are very highly likely to die, more than women, 3 times more in fact. Um, more women than men attempt, but most are not completing, and men complete mainly because they choose a more lethal means. A lot of times women will, take pills or do something like that for which someone can find them and save them, whereas men often will use a more lethal means like a gun that they can't come back from. And so with 90% of those who complete suicide have a diagnosable mental illness and substance use disorder. So if the person you're seeing is suicidal and they have mental illness or substance use disorder, they're a male and they have a firearm and they have a plan, that makes them high risk and probably would ask for less. Talking with clients about suicide, we talk to them about suicide. We ask about thoughts of suicide. That will actually reduce the chance that they will attempt or complete. You have to be careful the way you believe about it. You've got to bias everything you think about it. You have to be kind and empathetic. It's very scary for clients to talk about it. It's helpful to direct by naming suicide. It's not uncommon for someone feeling down and under a lot of stress to think of suicide. So I'm wondering when the last time was you thought about suicide. I use that a lot. I'm wondering if you're thinking about suicide. That's what I say. You need to say suicide, suicide, suicide. You need to get used to say it in the mirror. You need to start. You need to be so comfortable saying the word suicide. You might say it 6 times a day when you're practicing. I ask the question constantly. Are you thinking about suicide? When's the last time you thought about suicide? That kind of stuff. It's not exact science when you do an assessment. It's part of suicide risk assessment. It's a clinical interview. You evaluate the risk factors, like I just talked about from the stats, warning signs, isolation, access to means, etc. Understand the client's unique situation. If they have suicide, substance abuse, and other co-occurring disorders that would make them higher risk. And who their support is and what's keeping them, protective factors, what's keeping them from suiciding. Develop appropriate and responsive interventions to reduce risk, like a safety plan, and make sure they don't feel judged and they'll be comfortable talking to you. There are objective measures as well. There are suicide behavior questionnaires, suicide ideation scale, suicide status form. So when we do a class in 2 weeks, we'll go over these. And look, there's also Beck scale for suicidal ideation, brief reasons for living, depression rating scale. So of course we can't use the Milan or the Minnesota without proper training. But ideation is their thoughts. So non-judgmental assumptions that suicidal ideation might have been present. When was the last time you thought about killing yourself? When was the last time you thought about suicide? You are direct. You do not say hurting self, because don't use code words, because they could be self-injurious behaviors or something else, and like hitting their head in the wall. Just to be very clear that you're not. Don't beat around the bush. Very direct. You listen for and ask for the following: the frequency of the suicidal thoughts, duration, and intensity. And then you want to know if there's a plan. So these are the questions you're asking. When you've thought about suicide, what kind of things have you thought about? And you're looking for this. And we're going to do a lot of this, so don't worry about understanding exactly how this goes. But the SLAP acronym is specificity. So they're very specific about how I have a pistol in my bedside table that's loaded that I'm ready to use. Okay, very specific. Very specific. It was right. Lethality, very specific that it's a very lethal means. Whereas something that's not as lethal would be like, well, I've thought about taking an overdose of pills. Well, what kind of pills? Well, just whatever's in the medicine cabinet. Well, what's in the medicine cabinet? Well, I have Advil, and I read somewhere that if you take a bunch of Benadryl and Advil or whatever, it could kill me. Okay, so they have access to that, but how lethal is what's in the cabinet? And they just like blanketing that they would do it, so they don't have a specific plan. And the means isn't that lethal. So like overdosing on or killing yourself on Advil would be tough. It would make you really sick and you throw up, but it would be tough. And I don't know what's keeping them from doing it. What is their social support? Who's in their house? What's keeping them alive? Risk factors, these are the things I just talked to you about. You assess for risk. So these are the risk factors. You look for, are they male or female? Are they elderly or late adolescents? Divorced, widowed, single people are higher rate. Do they have a diagnosis of a mental illness? Do they have a prior suicide attempt? That is, anybody with a prior attempt is somebody who is very high risk for suicide. Family history also. Anybody in their family has completed suicide. Unemployment, access to firearms, military, PTSD, diagnosis. The warning signs are these. So these are different than risk factors. Warning signs are substance abuse, anxiety, agitation, social withdrawal, active psychosis, plans and preparation, not sleeping, flight into health. This is really important. Sometimes our clients all of a sudden like get better. And it's because they've decided to take their life and they go through this thing called flight into health. Talk about death or dying, or like, I just want to go to sleep and not get up. I wouldn't really kill myself, but I just wish I didn't have to do life. I want to go home, like home where? Like home to heaven, home to, stuff like that. Hopelessness. So, and then one of the best parts about what we do is we identify protective factors. What's keeping you safe for now? What are the things that are helping you not to make that choice to complete suicide? And they are these things. So family and friends, religious beliefs, healthy problem solving coping skills, restricting access to the gun. If I had someone with a plan to use a gun and it's in their bedside table, I just had this happen. I would call their spouse and have them remove all firearms from the residence where they have no access. They might hospitalize, it just depends on the assessment. So immediate interventions, the assessments and intervention, when you're asking, what has stopped you so far from attempting to end your life? What keeps you from doing it? A safety plan is what I do with all clients who are at all suicidal. More effective and ethical. How do we keep them safe? What are the coping mechanisms? What are the phone numbers to call? An overall risk assessment, there's extreme risk, high risk, moderate risk, and low risk. You really have to make a decision between extreme and high about hospitalization. Moderate and low, probably going to be able to handle outside with other support and monitoring. But we're going to go over that in detail when we get back to class.